Hi, my name is Dr. Douglas Green. I'm here at Jacksonville Hearing and Balance Institute, and I'm here with some friends, patients that are here, and with several of our providers. And we're excited to share some of the things that we've learned about vestibular migraine. And vestibular migraine is one of those things that's extremely common, and it's frequently misdiagnosed and unrecognized. So we're excited to share some of the things that we've learned about it. And let me first tell you a little bit about our institute. We've been here at the Jacksonville Hearing and Balance Institute since 1997. So coming up on 30 years, it's been an exciting 30 years. I'm a neurotologist, which is a subspecialty of ear, nose, and throat that focuses on the ear and balance and the brain and its related structures. And that's I have 3 physician assistants. You'll hear from 2 of them today. And I'm excited to introduce them to you, and 6 audiologists that help us to do what we do here. And they're the real, I couldn't do what I do without them. So grateful to have them. And we're happy to provide tertiary level care regarding these kinds of problems of the ears and nose and of the ears and related structures. This is the team, and you can see the audiologist, you can see the physician assistants there at the top, and then the 6 audiologists, and Lou on the lower right is an audiology assistant. And our mission statement, as you can see there, is to further the healing ministry of Christ through advanced diagnostic and therapeutic techniques to help patients with hearing, balance, and related ear problems in a caring and compassionate environment, which is financially sound, efficient, and proactive. So we hope this presentation will further that cause. So without further ado, I'm going to turn it over to Emerald Ford. She's one of our physician assistants here, and she's going to tell us about the anatomy and physiology of the vestibular system. People think of the inner ear, and there's a lot to it, and she's going to help teach us about it.
Hello. As Dr. Green said, my name's Emerald. I'm one of the PAs here at Jacksonville Hearing and Balance Institute. I am one of the newest clinicians to join the JHBI team. I just moved from Georgia about a year and a half ago to the lovely city of Jacksonville, and I was fortunate enough to join this lovely team. So I did want to talk about, give a little kind of background on some anatomy and physiology of the vestibular system before going into our dive on vestibular migraines. So here we have the inner ear balance or vestibular system. And this system is made up of a lot of little tiny structures that work together to help our brain sense motion and things like that as we move around throughout the world and kind of throughout space. So here we have the 3 semicircular canals. These canals basically tell the brain information about rotational movement and angular movement of the head. And then you also have in the inner ear the utricle and the saccule here. Those structures tell the brain information about linear motion, so kind of moving forwards and backwards, and also in respects to gravity, so kind of going up and down as well, like on an elevator. This structure here is basically filled with fluid. That fluid is called endolymph, and that fluid there, as it moves, as you move, as you turn your head, do different motions, that fluid stimulates all these little hair cells in the system, which starts to send signals and information to the brain in relation to dizziness, or in relation to motion and everything. When it comes to our balance and how our body works together to help us move and do motion and everything throughout our day, there are basically 4 major systems involved. We have the visual system here, which is basically our eyes, what we see in the world around us, what our brain kind of takes in from the world, basically. That sends information to the brain. Our vestibular system, as we just talked about. Our somatosensory input, which is basically information from our muscles, from our joints, from what we feel in the world around us. Basically, that also sends information to the brain to help us navigate and keep us upright and balanced and everything. And then also that 4th system that we sometimes don't always think about, but it's basically the brain, the central integration of it all. Basically, it takes information from all of these different systems and helps it work together to, again, maintain our balance and everything. One example of how the brain kind of integrates these systems is our vestibulo-ocular reflex, which is something that we do test and investigate here. That is basically this connection between the eyes, the visual system, and the vestibular system that kind of integrates information as we're moving and helps, again, us just do different things. Some things we don't even necessarily think are that complicated, but the brain kind of breaks it down and integrates that information. So an example of that is when you're walking, or if you're focused on a point, like when you're walking and looking at a sign, your eyes are able to stay focused on that sign as you're moving, and that's because of this, again, that connection between the visual and vestibular system kind of helps keep the eye stable. So that's one thing that kind of an example of how the brain integrates all this information. When it comes to vestibular migraines, so I do want to add, a problem in any one of these systems could certainly cause someone to feel dizzy or off balance. But when it comes to vestibular migraines, it's not always a problem in one of those systems, but sometimes the problem is in the central system here, where everything else is kind of normal, but the brain itself is kind of over sensitive or hypersensitive to external stimulus, so sometimes to normal stimulus. So an example of that is someone who has migraines. When we think about it, you've probably heard an example of them having light sensitivity, sound sensitivity. Well, with vestibular migraines, they're also kind of overstimulated by some of the normal motion and things like that that can make someone feel dizzy and whatnot. So I'm going to pass it over to Amy. She's my colleague, one of our Amy Busic, my colleague and physician assistant here. She's going to talk a little bit more about vestibular migraines.
Okay, so as Emerald said, my name's Amy Busic. I'm one of the physician assistants here at Jacksonville Hearing and Balance Institute. I've been with this group for a little over 4 years now, and I've kind of taken a little special interest in vestibular migraines. Go back. First and foremost, a migraine does not have to be a headache. For example, children get something called abdominal migraines. The primary symptom is belly pain. Tonight, we're talking about vestibular migraines, primary symptom being dizziness. Headaches, like I said, don't always have to accompany the dizziness. You can have the dizziness with or without headaches and still have a vestibular migraine. A lot of ways that people describe a vestibular migraine: vertigo, dizziness, imbalance, spatial disorientation lasting seconds to days. We hear all sorts of descriptions from our patients. Some of the more common things that we hear are lightheadedness, swimming sensation, heaviness in the head, rising sensation, tingling, rocking sensation, and increased motion susceptibility. Patients also very frequently will describe an ear fullness, ear pressure, hearing loss, muffled hearing, or tinnitus, which is ringing in the ears. All of these are symptoms of vestibular migraines. So who gets vestibular migraines? Migraines in and of themselves affect about 12% of the population. Vestibular migraines impacting about 1% of the population. That being said, like we talked about earlier, this percentage is likely a lot higher than that. This is just a very underdiagnosed, unrecognized sort of problem. Vestibular migraines more likely to occur in patients who have a personal or family history of traditional migraines. That history does not have to be there. It just makes you more prone to developing vestibular migraines. 5 times more likely in females. Mean age of onset, 37 in women, 42 in men. That being said, these can develop at any point throughout someone's lifetime. So the headache disorder classification system of vestibular migraines, the criteria: 5 moderate to severe episodes lasting 5 minutes to 72 hours, current or previous history of migraine, 1+ of the following with at least half of those episodes. This is your unilateral classic pulsing headache. And then, like Emerald mentioned earlier, the light and sound sensitivity or visual aura. Really important is that this is not better accounted for by another vestibular or neurological diagnosis. This is the reason we put our patients through a further vestibular test battery, which Dr. Kelly will hit on in just a few minutes. You can also have a vestibular disorder and vestibular migraines. That just further complicates the treatment of things. So why does this happen? Evidence is very limited. We know that genetic factors do play a role. That personal or family history of migraines definitely makes you more prone to developing them. The pathophysiology, how do migraines happen? This is a widely debated topic. There's been many different theories here to include vascular depolarization, trigeminal vascular system, decreased threshold to certain stimuli. I mean, it just goes on, and I think we're constantly changing throughout the years what our thought process is on the pathophysiology behind this. And then, oh, that was short and sweet. So I am going to hand it over to Dr. Kelly, who is one of our audiologists, to talk about how do we do this testing? What is the vestibular test battery?
All right. So like Amy said, I am Janelle Kelly. I'm one of the audiologists here. I've actually been here coming up to 10 years, which I cannot believe it's almost been 10 years here. One of my clinical loves, if you will, is this balance testing. This is my absolute favorite thing that I get to do here. You'll see that it's like little pieces of a puzzle, and we're going to go through all the different pieces of the puzzle and what they're testing. And then afterwards, it is my job to put the puzzle together, if you will, and see what picture it makes. So we call it the test battery because it's made up of several smaller tests. We are going to talk about computerized dynamic posturography, vestibular evoked myogenic potential, rotary chair testing, and video nystagmography. Now, all of those are quite a mouthful, so you'll see as I go through that I'm going to abbreviate everything. So first, computerized dynamic posturography, or what we call CDP for short. So how does it work? The patient is strapped into this machine. It almost looks like a half egg, almost like a dome on its side, if you will. They are also standing on a platform. So sometimes the platform is going to move, and sometimes the surrounding visual field is going to move. The patient's job is simply to stay as still and upright as possible. We do some of these conditions with the eyes open and with the eyes closed. So what are we testing in this dome-like contraption here? So we have previously talked about the three systems that our brain uses to stay upright. So we talked about the visual system, the vestibular system, or our inner ear, as well as the somatosensory system. So how our body knows where our weight is distributed. So those three things our brain uses to stay upright. So this machine is going to test those things as a team of three, in pairs, and then individually. So here's where we start to tease out, okay, is this truly a vestibular problem? Is this maybe an issue with the patient's eyes, or maybe something with the somatosensory or touch sensors on the bottom of their feet? Next, we're talking about vestibular myogenic potential, or what we call VEMP. This one is actually not as interesting to look at, so that's why I don't have a picture up. The patient is going to be just lying down. We ask the patient to turn their head to the right or to the left, and then they lift their head up so that the muscle on the side of the neck here, that sternocleidomastoid muscle, is going to be activated. They are hearing a thumping noise while this is happening. We do have electrodes around the face and the neck, and we're actually measuring a reflex that happens from the ear to our brainstem and then back down to that sternocleidomastoid muscle here, which is why we have an electrode right there. This is going to give us information about the saccule. My colleague Emerald mentioned a little bit about the saccule. So it is a little tiny organ that we have on both the right and the left side, and it gives us information about head movements in the vertical plane. So right now my saccule knows that my head is upright, and if I were to bend over, my saccule will know that my head is bent over, so that vertical plane there. It's also innervated by a portion of the 8th cranial nerve. The 8th cranial nerve is responsible for hearing and balance, and we actually have 3 branches on each side, so a total of 6 branches. So with this test, we're starting to tease out individual parts of the inner ear with both the saccule and then one of the branches of the 8th cranial nerve on each side. Next, we have rotary chair testing. Rotary chair testing is like what it sounds. It is a chair that rotates. So you'll see me at the controls, and I have a patient behind me there. She is in the chair, and that chair will move from side to side. We are also tracking that patient's eye movements, which is why she has a pair of goggles on. So basically, the long and short of it is the patient sits in the chair and then we ask them to perform various tasks. We have 3 kind of sub-tests in this part. It's going to be ocular motor testing, SVV testing, and Shaw testing. Ocular motor testing, ocular meaning eyes and motor meaning movement. So with ocular motor testing, we ask the patient to follow a light with their eyes without moving their head, and the light moves in various directions. SVV stands for subjective visual vertical. So we actually project a line onto the wall and it's tilted to one side or the other. And we have the patients make the line perfectly straight up and down so we can verify that their brain knows where up is. And then lastly, Shaw stands for sinusoidal accelerated harmonic acceleration there. So that is where the chair is going to turn. And the chair is never tilting upside down. It is turning and stopping, turning and stopping. The patient simply just needs to stay as still as possible with their eyes as open as possible so that we can track their eye movements throughout the testing. So it seems like a collection of random activities, but what are we testing with these sub-tests here? Ocular motor testing, we're actually looking at different levels of the brainstem and their function so that we can start to tease out, okay, is this truly a vestibular or ear problem, or is this going to be a central or brain problem? SVV is going to test the saccule counterpart, which is called the utricle that Emerald had briefly mentioned before. So the saccule is giving us information about head movements in the vertical plane. The utricle is giving us information about head movements in the horizontal plane. So my head knows that I'm tilted to the right versus tilted to the left. It is also innervated by another part of that 8th cranial nerve. So we are testing a part of that 8th cranial nerve there so that we can get a whole picture health picture there. And then lastly, Shaw is actually looking how the inner ears work as a team. We go about our life, obviously, with both of our inner ears. So we are wanting to make sure that they work as a team, and then Shaw lets us know how they are doing at that task. It's also the gold standard to determine if someone has an ear that is not just stronger than the other, but if both ears are weak. So if someone has a bilateral weakness, this is the gold standard in order to determine a bilateral weakness. And then lastly, we have video nisomography, or we shorten that to VNG. We again have sub-tests with VNG. We have 2 sub-tests here. We have positional testing and caloric testing. Positional testing, just like how it sounds, we put the patient into different positions. We are tracking their eye movements. We wanted to make sure if any positions triggers dizziness, because that is a form of dizziness. And then caloric testing, better known as the water test. So with caloric testing, we put cool and then warm water into the patient's ears, and it actually can trigger some dizziness. It's very short-lived. It's about 40 to maybe 60 seconds of dizziness. As soon as the ear returns to its normal body temperature, that feeling will go away. But throughout the entire test, we are again looking at the patient's eye movements that gives us clues into what's happening in the inner ear. So again, seemingly random tasks. What are we actually testing here? With positional testing, we are actually looking for possible BPPV. That is the crystals that are in the inner ear, and sometimes they fall out of place. We're not really talking about that for this presentation today, but it is a very common form of dizziness. It also helps us determine if it is truly an ear problem or is it a central problem or an issue with the brain. It helps us tease out that information as well. And then lastly, the caloric testing gives us information of the last branch of that 8th cranial nerve so that we are able to test all 6 branches of both cranial nerve 8s there. And it also gives us very ear-specific information, so we can definitely determine, okay, the right ear is weak, okay, the left ear is weak, as well as, okay, both ears are weak, they have a bilateral weakness. All right, so now that we have all of the testing done and all of the pieces of the puzzle, we put it together and then we talk about treatment. And I'm going to hand it over to Dr. Green now to talk more about treatment specifically for vestibular migraine.
Thank you so much, Janelle. Treatment is one of those things that is really probably better described as management or control. So I like to make the comparison when I talk with patients about arthritis. So if I were to ask the average person, is there a cure for arthritis? You'd say, no, there's not a cure for arthritis. You manage it, you control it. And migraines are very much like that. You control them. And I have arthritis in my knee, but it doesn't really bother me. So I manage it. If it gets bad, I might take a medication, but it's managed. And it's very much a good analogy with migraines. So the idea with migraines and migraine management is to elevate the migraine threshold so that patients are not getting a migraine in situations where they might have otherwise, not getting a migraine vertigo problem where they might have gotten one otherwise. And it's very analogous to what's done with headaches. So people get breakthrough headaches sometimes due to diet or physiologic factors. Menstrual cycle headaches are an extremely common physiologic factor for females. And as was mentioned earlier, females have a predisposition to not only migraine headaches, but migraine vertigo as well. Environmental factors, genetics. There are significant genetic factors that go along with it, probably related to some of the little calcium channels within the nerves of the brain that make the nerve cells more susceptible. There's still a lot to learn about that, but we are learning it. One of the things that also has a significant role is weather. And if you talk to people that have migraine headaches, they'll tell you, gosh, I can tell when a front's coming in. That same type of thing happens with migraine-related vertigo. So I want to focus both on the medication-related treatments and on the non-medication-related types of things. So this is one of those situations where a lot of times vitamins and things like that can be helpful. So vitamin B2 riboflavin has been shown to be helpful, along with magnesium, and coenzyme Q10 is one of the things that's been helpful. You want to check with your physician before taking those medications, but many of our patients do find that to be helpful. Hydration. Dehydration seems to make it worse, and certainly here in Florida, where it's hot and people are perspiring, that is a significant problem. So drinking plenty of fluids is essential to help prevent that. And then sleep. Important to keep in mind how important sleep is. We're learning more and more about how sleep is restorative. That's where your brain kind of recharges and new neural pathways are developed during sleep. And so one of the important things is to really maximize sleep. And screen time, blue light with screens are one of those things that's been shown to be to harm sleep and avoiding, and then to be avoided, and then large meals and alcohol, caffeine, things like that do that do make it harder to fall asleep and interfere with sleep. And then a consistent sleep schedule. Many of our patients will tell us, yeah, that maybe I traveled, I went over to Europe or someplace, and I don't sleep well, and then the migraines come on. It's a very significant thing to have a consistent sleep pattern, and extremely important, and can't emphasize that enough. So screen time, many of our patients will describe motion sensitivity with their screens. So they're on a computer. Many of our patients nowadays work on a screen. They'll work on a computer screen, and they'll say, well, gosh, I had a guy the other day that had like 5 different screens in front of him, and there's all this movement and activity. And many of our patients find that it helps. They have to know what their limits are with the screens. So sometimes they'll say, I can go 45 minutes, but if I go much past that, my equilibrium goes off and I start having symptoms. And fluorescent lighting is a problem for some of our patients. So frequently they'll say, can you turn off the lights in the room? The fluorescent lighting is really getting to me. And that can be important. I mentioned blue light before. Some of our patients have found that helpful, to where glasses that filter blue light, or to put a blue light screen over their computer or over their phone or tablet, and that can be extremely helpful. Stress management. I want to really emphasize stress management. There was a great study done by Dr. Sharon at the University of California, San Francisco. And at that study, they put their patients into one of two categories. So they offered nothing more than stress management. And this was a meeting with a counselor on a weekly basis and reading a book about stress management. And then they basically answered some questionnaires. So one group had the stress management, one group didn't have the stress management. The group that had the stress management, no medications, nothing other than the stress management intervention, had a 50% reduction in their migraine-related vertigo. So we tend to poo-poo stress management. We say, oh, stress, that's just part of life. You can't. No, you can manage stress. You can do things to help with stress. Sleep is one of those things that helps with stress. Relationships with other people, talking about stressful situations helps to relieve stress. There are sometimes it's helpful to, stress relief can be just something like reading a book. Meditation has been shown to be extremely helpful for stress, and we encourage that for our patients as well. So really, really important and can't be overemphasized. Dietary triggers. We know that migraine headaches are triggered by certain dietary foods. Red wines are the classic. Certain cheeses are also the classic. Caffeine and chocolate for some patients. MSG, monosodium glutamate, is another one. Nitrates. There's a number of different things that can be triggers that are dietary. One of the things that I mentioned to our patients is to kind of know yourself, know thyself, the old Socratic saying, know what you can eat, what you can do, what triggers it, and then obviously avoidance of those things and good stress management. Those will help tremendously in managing the migraine-related problems. A couple of books that we really encourage our patients to read. One is Heal Your Headache by Dr. Buchholz, and it's really geared towards headache, but a lot of those same principles apply to the migraine vertigo problem. So worthwhile to do that. And then there are many of our patients that find it helpful to go through what we call kind of a migraine diet. It turns out that tryptophans are a neurotransmitter in your brain that is important in migraines. So one of the things you can do to limit the amount of tryptophans that your body creates is to alter your diet. And there's a migraine diet. It's described in this book called The Dizzy Cook, and it's a great way to kind of manage the diet in ways that are in a way that's favorable. So let's kind of turn to some of the medications, because I think unfortunately a lot of times in our society we go to the doctor and we say, I want a pill that manages that medicine. And there's lots of different medicines that are out there. This is a list of some of the older medicines that we use at times, and we'll kind of take these kind of one by one. Nortriptyline is an older medication originally developed for depression, but it works well for migraine-related vertigo. It has an effect that's positive because it has a little bit of a sedation effect when someone takes it at bedtime. So we think it helps them to sleep a little bit better. It also helps to reduce the anxiety and depression that can be factors in the migraine-related dizziness. Topamax is a medication that was originally developed years ago for seizures. And what they found in many of the patients that were getting seizures is their migraine headaches went away. So it's actually used primarily for that. It's a kind of a harsh medicine. Many of our patients find they get that it's not difficult to tolerate. It causes some brain fog and other things that make it tricky to use. But many of our patients do find that to be a good, readily available treatment. Verapamil is a group of medications called calcium channel blockers. They're commonly used for high blood pressure, but we know that they work well for the migraines as well. A little bit less commonly used than the topiramate and the nortriptyline. Propranolol is a medication some of you may be familiar with. It's called a beta blocker. It's commonly used to help with, to some degree, blood pressure. It helps reduce anxiety. It's used after someone has a heart attack to keep the system regulated. And then Effexor or venlafaxine is a newer medication. It's a medication that works in two different sites. It works with norepinephrine to regulate the norepinephrine, and also works with another neuroregulator called dopamine. And so it helps with both of those, and is extremely helpful in that it hits more than one receptor site. So it's one of the go-tos. Venlafaxine and nortriptyline are two that I really do like and that we use quite a bit. Let's switch gears to some of the newer ones, and I will just tell you that these newer medications are growing just week by week. It seems like there's a new CGRP or GPANT medication. So CGRP stands for calcitonin gene-related peptide, CGRP. And CGRP is a neurotransmitter that is in the brain that has been found to be important in migraine headaches developing. Surprisingly, they've also found this actually in the inner ear. And so it's also in the inner ear. So both of these groups of medications, all these medications work on this same particular substance, CGRP. And there's basically two different types of medications. These were originally developed for, some of them were developed for rescue. When someone gets a headache, they would take these medications. And then the other group of medications are medications that are used to prevent migraine. So kind of two different groups. For instance, Emgality there at the bottom is an injectable medication. It's a CGRP inhibitor. So it basically blocks the receptor sites for the CGRP. And in doing that, it helps to prevent headaches. So it's an injection that's given, and we work closely with our neurological colleagues with these medications. Other medications like Nurtec and Ubrelvy and Qulipta are medicines that are different. They're medicines that are antagonists. So they basically are very much like the CGRP, but they don't have the activity that it has. So basically, they go to the receptor site and activate that site and block the active CRGP from working. So they can be used in our patients who are having a migraine vertigo attack to help stop that attack. And there's lots of research going on. These medicines were obviously developed for the headaches, but they're being used more and more now for treatment of the migraine problems that can happen with migraine-related vertigo. And there's a lot of interest in them. They are newer medications, and like a lot of the newer medications, they are more expensive. So it is tricky to get insurance approval, and sometimes we'll get samples or other things that we can use, but it is tricky to use these medications, even though we have had some good success for some of our patients with them. So just to kind of summarize, vestibular migraines are unique, and everybody has a different story, a different symptom. And it's important for us to kind of understand it, but almost any part of your brain can be affected and can have migraine-related problems. So we see a little bit of everything, and it can vary quite a bit. It's exciting, some of the research that's ongoing. When I started this process of taking care of patients with vestibular problems back in the 80s, late 80s and early 90s, migraine-related problems, we didn't even think about it. We thought everything that caused you to be dizzy was from your inner ear. And so the research and the changes over the years, I remember when a doctor in the 90s wrote a paper on migraine-related vertigo, Dr. Jim Olson in San Antonio, and everybody thought, this guy's just nuts, this doesn't happen. But time has shown that his research and efforts at that time were extremely timely and right on. The testing is important. One of the things that we see, and Amy alluded to this, is combinations of problems. So we'll see some of our patients might have positional vertigo and they might have migraine problems, and that makes it much worse. So what might have been a minor dizziness problem becomes a major dizziness because of that sensitivity that goes along with the migraine problem. Someone might have Meniere's disease where they get spells of vertigo, and those spells and vertigos are so much worse because of the coexistent migraine problem. And we're seeing and learning more and more about these coexisting problems. And there's lots and lots of, so understanding the balance system is more and more important to be able to deal with this on an individualized basis. And then the exciting thing is that treatment is available, both medicinal and non-medicinal treatments. And again, a lot of the treatments, it sounds kind of crazy, but a lot of times people will come in wanting a pill and we'll say, gosh, this treatment, the best treatment for you is stress management, getting good sleep, doing things of that nature, taking this particular, taking magnesium or some other type of a vitamin. So treatment is management, and management is definitely the way to go.